the single most important decision you can make to improve your pregnancy outcome. And if you're taking notes, you want to write this down. Your OB-GYN cannot be the only expert in the room, right? I don't go into this with like a carbon copy, one size fits all. This is what everybody's experience is going to be. It literally looks like a little crochet hook, like a little hook, and you just snag the bag of water. Monitoring can be intermittent. It can be continuous. Alternative pain options if you are choosing to or want to consider declining the epidural. There are several positions in which you can choose to push in. The labor shake, something that almost all of us experience, but hardly anybody talks about. It's very common for most first-time moms to tear. Some moms will take their placenta home and encapsulate it, and then later ingest it for reasons such as Welcome to this week's episode of the Black Birth Stories podcast. I'm your host, Dr. Tiffany Wittes. I'm a wife, a mama, and a board-certified OB-GYN on a mission to help eliminate women's health disparities and improve Black maternal health outcomes. I help you take back control of your birth story without the fear of becoming a victim of the Black maternal health crisis. Each week, we amplify the voices of Black women in our unique birthing experiences, creating an environment for learning, for healing, and for empowerment. Be sure and follow us on Apple Podcasts, Spotify, and YouTube so that you don't miss an episode. Your choice of OB provider is the single most important decision you can make to improve your pregnancy outcome. And I firmly believe that we are the only ones who can take care of us the way that we need to be taken care of. And that is not just my opinion. Black patients with Black doctors equal better outcomes. Black patients with Black doctors are more likely to report receiving all needed medical services. Black patients with Black doctors are more likely to report receiving preventative care. Black patients with Black doctors are more likely to express greater satisfaction with their care. Black patients with Black doctors have longer life expectancies. Black infants cared for by Black doctors have lower infant mortality rates. But here is the reality. The reality is that only 5% of physicians are Black. The reality is that less than 5% of midwives are Black. And so at the end of the day, you need to know how to advocate for yourself regardless. We get the strength, the education, the support that we need to advocate for ourselves within the context of community. Our story has always been rooted and grounded in community. As a people, our ability to survive and thrive has always been tied to community. And this situation is no different. Activate your village. Never go into a medical setting without your village. It takes a village to birth a mother. It takes a village to keep that mother safe. What does a village look like? Your village can look like informed family and friends. Your village can look like a doula. Your village can look like a lactation consultant, a social worker, a mental health therapist, spiritual support. Your village can be a digital Black birth community. My favorite one is Melanin Maternity, which you can learn more about by visiting melaninmaternity.com. The village is so critically important. I'm going to let you in on a secret. As a healthcare provider, when a patient approaches you with a question, a concern, a grievance, it is so much easier to dismiss that one person, to blow them off, to disregard their concerns. But when a group of people are sitting across from you, me, as a healthcare provider, expressing those same grievances, concerns, it is so much harder when you know that you're accountable to a group of people to dismiss and disregard their concerns. Never go into these settings without your village.
These are the worst mistakes Black women can make when choosing an OBGYN, assuming they'll automatically prioritize your safety, ignoring the signs when they dismiss your concerns, and not having a plan to advocate for yourself. Sis, I've been there, and that's why I'm so glad I found the Mocha Maternity Survival Guide, Choosing the Right OBGYN. This guide gave me everything I needed to avoid those mistakes, from conversation starters to tools for assessing their care. It's the ultimate roadmap to make sure you're seen, heard, and protected. Don't take chances with your health. Get your copy today and make the choice that could change everything.
Prepare yourself before you get into these medical settings. What does that look like? That looks like writing your questions down and bringing them with you. That looks like educating yourself, right? If you don't take the time to educate yourself, you leave yourself at the mercy of what someone chooses to tell you and what they choose not to tell you. You also need to prepare a toolkit, frameworks that you can pull out when needed and use when it becomes necessary. I'll give you some examples. I like to arm mamas with a toolkit of helpful medical terms. Here's an example. You're 34 weeks pregnant. You go into your OB/GYN office just for a routine prenatal visit. The MA takes your blood pressure. You notice that your blood pressure is a little higher and it's been that way for the last 2 visits. You bring this up to your doctor and your doctor says, it's probably nothing, probably just stress. I wouldn't worry about it. I want you to take a breath. Assume good intent, slow that doctor down, and say this. And if you're taking notes, you want to write this down. Okay, what is my differential diagnosis? Aha! When medical professionals hear medical terms quoted back to them, they sit up a little straighter. They get themselves together and come correct because they know that they're talking to someone who either knows what they're talking about or knows someone who knows what they are talking about. Differential diagnosis is just medical speak for what else could this be? And then you hit them with a follow-up question, which is, and what have we done to make sure it's not that? Lastly, I want you to have a birth preference form, also known as a birth plan, but I prefer preference form because plan sets you up for disappointment when things go left. A birth preference form allows you to expand your mind, consider scenarios that would not have otherwise been on your birth plan, right? The plan was not to have a C-section. But since I took the time to think through what I would want my experience to be like in the event that I need that, it helps to take down some of the fear, the anxiety, the disappointment when things do not go as planned. Let's talk about the significance and the importance of doulas. A doula is a continuous non-medical support person that can help support and advocate for you during pregnancy, on labor and delivery, and in the postpartum period. Mamas who look like us, who have doulas on their teams, have much, much better birthing experiences, right? It takes a village to birth a mama. It takes a village to keep a mama safe, and your OB/GYN cannot be the only expert in the room, right? This is a team sport. It requires a team to keep you safe. We need doulas. We need each other. We need that village. Your OB/GYN is not going to be at your side 24/7. They need someone to be an extension of them, to be their eyes, their ears, to bring up any questions or concerns that sometimes they may miss because they're not going to be at your side 24/7. They also provide much needed education in terms of helping to break down and explain maybe medical terminology that you're hearing, diagnoses that you're receiving, procedures that are being recommended to you. Mamas with doulas have much more satisfying birth experiences. We see lower intervention rates, lower C-section rates, lower reliance on pain medication, healthier mamas, healthier babies, higher breastfeeding rates. The benefits just go on and on and on. I believe that every birthing mama should have a doula. Patients who stay at home as long as possible have a better labor and delivery experience, period, right? You're in your safe place at home where your comfort is, where you can be in your own bed, in your own space. You don't have the restrictions, the rules, the regulations that you can sometimes face in a hospital setting. You don't feel the anxiousness, the worry, the fear that sometimes can come along with being a sterile medical setting. So I find that patients have a much better labor and delivery experience when they stay at home as long as possible. Now, I do not want you scared or worried at home. If we've crossed that line, it's time to come into the hospital. I do not want you to have any concerns. For example, baby should be moving in between those contractions. You should not be bleeding like a period, right? You can have light bleeding, spotting sometimes in early labor. We call that the bloody show of labor, as that cervix is dilating and the cervix is just more sensitive in general as we get closer to our due date, and especially in labor. Those tiny blood vessels are breaking as your cervix is dilating. This is more like blood-tinged mucousy discharge. This is not a put on a pad and filled up the pad, right? We don't want you in excruciating pain. If we've crossed that line, it's time to come into the hospital. And if your bag of water has broken, you need to have a conversation with your healthcare provider to ask them, how long do I have before I need to come into the hospital? Some things to consider. For example, if you're GBS positive and this is not your first baby, you probably need to come in sooner rather than later, because we need to give antibiotics to you so that we can get enough time to pass that from the mama through the placenta to the baby, so that the baby is covered covered and protected from being exposed to this life-threatening potential infection. For example, if you are a multip, as in this is not your first baby and you're already walking around at lag 3-4 centimeters, you probably need to come in sooner rather than later if you suspect that your bag of water is broken, because it may not take you that long to labor, right? If you have a history of really fast or precipitous labors, you need to come in sooner rather than later. So that's a conversation that you have to have an individualized discussion with your healthcare provider. But I do find that mamas who do the bulk of the work at home prior to coming into the hospital have a much, much better labor and delivery experience. Let's talk about labor inductions. There are two basic types of inductions. One is an elective induction and the other is a medical induction. An elective induction can be done after 39 weeks and is done without a maternal or fetal indication for induction. Medical inductions, on the other hand, would be done because of a maternal or fetal indication for that induction. There are lots of different types of medical inductions. There are medical inductions for maternal indications and medical inductions for fetal indications. Some examples of inductions for maternal indications include things like high blood pressure, hypertensive disorders of pregnancy, poorly controlled blood sugars at term. When it comes to fetal reasons for induction, this might include things like evidence of fetal distress, for example. A landmark study called the ARRIVE trial, which was published in 2018, really gave us great information about how to approach and understand labor inductions and the implications of inductions. This was a huge study that looked at elective inductions in first-time moms and actually showed us that when you look at these moms who were induced electively at 39 weeks and compared them to those moms who were undergoing expectant management, as in just spontaneous onset of labor, we actually saw a decrease in the rates of cesarean deliveries in those moms undergoing elective inductions. Now, this applies to low-risk, nulliparous moms, as in moms who had not yet had any babies. We also did not see any significant increase in morbidity for both mom or baby, and now understand that it's reasonable to consider an elective induction at 39 weeks for an elective indication, as well as for maternal or fetal indications as well. There are a lot of things that we look at when it comes to whether or not someone is favorable to undergo a labor induction. There's a score that we calculate called the Bishop score, which looks at several different characteristics of someone's exam in order to inform us about how likely we are to be successful at a vaginal delivery for someone who is undergoing a labor induction. There are a couple of characteristics that we look at. The first is that mama already starting to dilate? What is the position of that cervix? Is it posterior behind the baby's head, or is it in a more mid or anterior position? What is the consistency of the cervix? Is it super firm, like the end of your nose, or is it floppy like a wet pancake, and is it starting to efface? And the higher the score is, as in the more characteristics of favorability someone has, the more likelihood that they're going to be successful at a vaginal delivery. It is not unusual for mamas who are not first-time mamas to walk around at 2, 3, maybe even 4 centimeters and not be in labor, because you're not in labor until you have those regular, consistent, strong labor contractions that are actively changing your cervix. So it's those Braxton Hicks contractions that she's likely been experiencing this whole way through that have softened and prepared her cervix for labor. She mentioned Cervical. There are a couple of different ways to approach inductions. One of the go-tos is to start with a measured approach, as in a slow and steady approach that helps to first prepare the cervix for labor before we go full in with strong labor contractions. There are medicines called prostaglandins, which are either given by mouth or can be placed vaginally, that will help soften and prepare the cervix for labor. Think of them as doing kind of what Braxton Hicks contractions do. They'll get you revved up, contracting irregularly. Usually these contractions are very tolerable, but this slow and steady approach really helps prepare that cervix for labor and improve the likelihood that we're going to be successful, especially with first-time mamas. Other types of induction might include mechanical inductions. So for example, stripping the membranes would be an example of mechanical induction. So this is a really aggressive cervical exam, which is typically done after about 39 weeks, where a cervical check is done and the provider will reach up as high as they can and kind of ream out the cervix. And yes, It is as painful as it sounds, a very aggressive cervical exam. Definitely should not be done without a thorough discussion and without consent prior to it being done. But essentially, it revs up hormones and helps to separate, literally physically separate where the cervix and the membranes meet up in order to make space, create space in that layer, and increasing the hormones often kickstarts that mama into labor. There are other mechanical ways to induce labor, such as a Cook catheter, which is very similar to a Foley bowl, except the Foley doesn't go in the bladder this time. This time it's going in the cervix, and it simulates what the head would do if the head was low enough to push against the cervix, because you need that head, that skull pushing against the cervix along with those labor contractions, those labor forces, to really dilate the cervix. And so those are mechanical ways to induce labor. I've also had moms use their breast pump. We know that oxytocin, which is the hormone that allows us to have milk let down, it's the thing that makes us contract. So I've had moms use their breast pump in order to induce labor. You guys have probably heard the saying that the way that you got the baby in there is the way that you get the baby out as well. So physical intimacy is something that can be used to rev up oxytocin and other hormones that can also lead to contractions that can help to induce the onset of labor as well.
Think about it. How many hands helped raise you? How many voices spoke life over you? How many arms held you close? Black family is deep, and at Melanin Maternity, we celebrate every single part of it. We're not just a shop for mamas. We're a love letter to the entire village. From keepsake birth announcements that honor your newest blessing, to new dad gifts, to presents for the grandma who still prays over you, we have gifts that tell your family's story. Looking for holiday gear that actually represents us? We got that too, because whether you're the one having the baby or the one making sure the baby always has love, you deserve to be celebrated. Shop Melanin Maternity on Etsy today by visiting melaninmaternity.etsy.com, because our families, our stories, and our legacies deserve the spotlight.
So that was a beautiful look at the fetal heart rate tracing. So this mama is on the monitor, and we just were able to see what's called the fetal heart rate tracing, or FHTs. So what we were looking at is that top number where we saw all of the up and down sawtooth activity and the beautiful accelerations above baseline. So think of the being on the monitor or the fetal heart rate tracing as a vital sign. It's like taking a temperature or a blood pressure. It's our way to assess how baby is doing during the labor process. So by looking at that heart rate tracing, we can get an indication about whether or not baby is responding well, or if there is any indication of potential fetal distress. It gives us an opportunity to identify the concern and intervene on the concern in an effort to improve our outcomes sooner rather than later. That was a beautifully reactive strip. That baby is looking really, really good. We saw lots of up and down sawtooth movement in that baseline heart rate. Remember, we've talked about a normal baseline heart rate is anywhere from 110s to 160s. We saw beautiful accelerations above the baseline, which is also an indication of fetal health and well-being. So we start to get concerned when we start to lose that variation, that sawtooth up and down variation in the heart rate tracing. Sometimes that can be an indication of maybe medications that could be on board. So for example, mamas who are dealing with things like severe preeclampsia, the treatment oftentimes is to put those mamas on magnesium. Magnesium acts as a sedative, so you'll see a softening or a flattening of that heart rate tracing. Other medicines like the pain medicines that we use, the Statols, the Demerols, the morphines, that type of thing, are also sedative medicines. So with those medicines on board, you'll also lose that variation in the heart rate tracing. And other times, at loss of variation, especially over long periods of time, that does not recover, can be an indication of fetal compromise. So that's one thing. Loss of accelerations above the baseline can also be something that we need to pay attention to. Could also be an indication of fetal compromise. We also start to look at whether or not there are dips below the baseline or decelerations. It depends on when those decelerations are happening as to whether or not they are concerning. So if you see just a quick blip that goes right below the baseline and then quickly returns, a lot of times that has to do with compression of the cord, which can happen when fluid levels are low. Remember, this mom is being induced for oligo or low fluid levels. How quickly that deceleration recovers, how it dips below the baseline and comes right back up and then looks good in between, are all things that we pay attention to when it comes to assessing fetal health and well-being. If we see those decelerations with the contraction, that's often an indication of head compression, which happens as that baby is in position in the birth canal, moving lower in the pelvis, getting ready for delivery. So not always an indication of concern unless those decelerations are super low and that baby is struggling to recover or come back up to its baseline heart rate. And then other times there can be decelerations that are concerning. For example, decelerations that happen after the contraction that has a slower, prolonged journey back to the baby's baseline can be concerning for fetal compromise. Oftentimes you'll see another line underneath baby's heart rate tracing that is mama's heart rates, that we're comparing the two to make sure that mama's doing well. It also helps us distinguish which heart rate are we listening to. Is this mama or is this baby? And then at the bottom, we see her contraction pattern. So you see beautiful mountains or hills at the bottom. You can get an indication of when those contractions are happening, how often they are happening as well, because we know what the contraction pattern needs to be in order to keep us making good forward progress during the labor journey. Monitoring can be intermittent. It can be continuous. Intermittent monitoring is typically going to be in a low-risk mama, typically not one who's undergoing an induction, but more likely someone who comes in spontaneous labor. And there are different protocols for intermittent monitoring. One that I typically do is to look and see what the heart tones are about every 30 minutes, unless the situation changes. Continuous monitor would be where you have the heart rate monitor and then the tachometer, which is what measures the contractions on your abdomen at all times. For mobile monitors, and you should definitely have a conversation with your facility to see if that is an option for you. Mobile monitors will allow you to get up and move freely so that you don't feel like you're confined to the bed, strapped down to the bed, and you definitely have the freedom of movement. Even if mobile monitors are not available, a lot of facilities have monitors with super long cords, which will still allow you to get up and walk around, be on a birthing ball, be in a chair, using a squat bar, be in different positions. All of that is still feasible while being monitored. Now, for mamas who want to have an unmedicated labor, you need to make sure that you're with a provider who supports your wishes. And you also need to make sure that you have a good game plan to tackle the discomfort that you are going to experience on that journey. I recommend to mamas who really are set on having a natural experience, as in no pain medication, to have a doula on board. You really need someone who's going to prepare you both mentally and physically for what you're going to endure in labor and delivery. For most mamas, this is not something that you just stumble into. You really have to be of the mindset and have the determination that this is the route you're going to take. You also need people around you who are going to fortify you, hold your arms up, uplift you, and remind you that this was your wish from the beginning, and then respect your decisions should you choose to change your mind, because it is not set in stone and you can definitely change your mind at any point in time. You also want to make sure that you know what is available to you in terms of alternative pain options if you are choosing to or want to consider declining the epidural. So for example, in the early stages of labor, and really throughout any stage of labor, we know that movement is golden in labor and can really help you manage some of the labor forces that you will experience. Being in water hydrotherapy is very calming and soothing and can help you deal with labor contractions. Being in different positions, being on a birthing ball, all of these things. Support from your partner can also help you manage some of the discomfort that you're experiencing in labor. Aromatherapy, massage, a focal point from home, all of these things can be conservative ways to deal with pain during labor. Labor and delivery units may also offer you nitrous oxide, which is a mixture of nitrous oxide and oxygen. It's kind of like laughing gas, which is also very safe and effective in helping deal with anxiety and pain on labor and delivery. So that could be an alternative, an acceptable alternative to the labor epidural. And then also there are IV pain medicines that can be given as well. Now, these are going to be very strong medicines. This is more like morphine, Demerol, Stadol, very strong medicines. So when these medicines are on board, they do inhibit your ability to get up and be more mobile because it's dangerous. You become a fall risk. However, we can still do a lot in terms of movement to keep your pelvis open, or things like the peanut ball between your legs. Different positions can still be done with those medicines on board in order to make sure that we're keeping that pelvis open to help baby navigate through the pelvis. It's important to have a conversation about IV pain medicine with your physician, your provider in your birth facility, because there can be some rules and restrictions in terms of the monitoring of baby after delivery. So for example, in my facility, if those medicines are given within 4 hours of delivery, because they are sedative medicines and very strong medicines, the same way that they make you sleepy, drowsy, they can also make baby very sleepy and drowsy. And so with that being said, the NICU team has to be present at time of delivery to do baby's initial assessments to make sure that baby makes it through that transition, okay? Because of those medicines being on board. And if those medicines are given within 2 hours of delivery, My facility actually requires that the baby go and be watched in the nursery for that transitional period, because sometimes babies can be so sedated that they forget to breathe. Now, breathing is optional while, they're in the womb, but it's not optional out here. My facility requires that those babies be watched one-on-one so that we can make sure that they are staying safe and healthy. And then, of course, there is the labor epidural.
So just to refresh your memory, the epidural is basically a tiny IV, kind of like the one you have there, but much, much smaller. We place outside the spinal cord. It's going to deliver numbing medication, ease of pain and delivery. Once the epidural is in and working, it'll be numb from about here down. You have to stay in bed, no food or drink after the epidural is in place. We'll do the procedure here in the room. I'll be behind you. We want to keep everything behind you sterile and clean, so it'll be important for you not to reach behind while we do this. But basically what I'll do is clean off your back with some soap, numb the skin on your back, and sort of hollow needle through the skin. Once I get the needle just outside the spinal cord, I'll thread that IV or catheter through the needle. We take the needle out, leave the catheter in. We do a couple tests to make sure the catheter's not in a bad spot. If everything tests well, we'll be able to continue using the epidural.
Okay.
So as you know, it's a safe procedure, but it does have potential risks like any other procedure that we do.
Great communication from this provider about the ins and outs of the labor epidural. This was shared decision-making and informed consent, done very, very well. So remember, anytime you're facing a medical decision, pull out your brain framework. What are the benefits of this procedure? What are the risks associated with this procedure? What are the indications or the reason why it's being recommended to me? And what does my intuition tell me about it? What are the alternatives? What else can I do? What happens if I do nothing? And how much time do I have to make a decision? And then at the end of the day, make sure that all of your questions and concerns are addressed before you give or withhold your consent. Your ability to eat on labor and delivery has been a source of debate for quite some time. Have a thorough conversation with your OB provider and your facility to find out what their policies are and what their preferences are. In my personal practice, for a low-risk mama, I have no issues with them eating a light diet. You need the energy that staying hydrated and eating gives you. We are about to ask you to run a marathon, and that is after, especially in an induction situation, that's after attempting to get you to go into labor for sometimes 1, 2, 2.5 days. Can you imagine getting to the end of that race and then me asking you to, all right, come on, let's go. I need you to push for me. Let's get it. Find the strength and energy. No. You need to stay fortified with food. Now, I tell mamas, don't eat anything that you don't mind seeing again, because we do see quite a bit of nausea, vomiting on labor and delivery, because sometimes when that stomach contracts, everything contracts and whatever is in that stomach comes right on back up. So keep that in mind. But for a low risk mama, no concern with either a clear liquid diet or a regular diet, especially as we're in the beginning starting the induction process. Now, if a concern comes up, if the situation changes, if we're starting to see signs that we might be at increased risk for an operative delivery or a C-section, then it's reasonable to pull back to a clear liquid diet, which is like jellos, juices, soup broths, water, ice chips, popsicles, that type of thing, because of the concerns with the anesthesia and the anesthesia that's necessary to safely perform an operative delivery won't allow you always to protect your airways. So if there's a lot of heavy food in your stomach, and it can reflux up into your lungs and be life-threatening for you. So definitely have a conversation with your OB provider and find out what the policies are. Include that in your birth plan so that you are prepared ahead of time. We definitely don't want you laying in the labor bed the entire induction. Movement, again, is golden in labor. And this particular activity that she's doing, it simulates curve walking, right? So she's doing motions and activities that help to open that pelvis up and make it easier for baby to move through the birth canal. So this is beautiful. It's kind of a fine line, resting, conserving your energy versus being up and mobile to help facilitate the labor process. You have to do what your body feels good doing. You have to find your own balance. We definitely don't want you to be in the bed the whole time, but we want you to conserve your energy because, again, this is a marathon, and at the end, only you can run it, right? I can't push for you. Your midwife, your doctor can't push for you, so you have to be able to muster and conserve the energy in order to do that. During a labor induction, there aren't any real prescribed time periods when we check your cervix. I don't go into this with a carbon copy, one size fits all. This is what everybody's experience is going to be. So I don't have rules we check your cervix every 2 hours, we check your cervix every 4 hours. I'm very low intervention. And so I do things when there is an indication to do it. So for example, if we start to see changes in the heart rate tracing, if you're on the monitor, where we might want to investigate and it looks like we're potentially progressing, we might go ahead and check your cervix and see. If mama is feeling more pressure and she feels like she needs to be checked, she's starting to feel like she, is having pressure on the rectum, or can just feel that things are progressing, sometimes we'll take a look and check. Other times, if it's been quite some time and we're not making good forward progress, let's say things have been a little bit quiet and it's been 4 to 6 hours, we might go ahead and check. But in general, you want to avoid frequent cervical exams. They should be done only when necessary, because the thing is, there's bacteria all over the vagina. Now, this is particularly the case if your bag of water is broken, and it's unavoidable. We can't clean all the bacteria away. And so each and every time you have a cervical check, we're potentially pushing that bacteria from the vagina into the bag of water and increasing your risk for infection. So that's just something to keep in mind. So bringing things from home that will help center and ground you and just give you a sense of calm and peace are very, very important, especially if you're delivering in a hospital setting. So I love those Starry Night projectors. I have patients who will put up string lights. You can put up affirmations. You can bring something from home. Maybe it's something from a loved one or a favorite this or that just helps to give you peace and can be soothing for you. All of those things, putting forethought into those things really goes a long way towards customizing this experience, personalizing this experience, taking down the intimidation in this experience, and making it more custom to what you desire it to be. Breaking the bag of water, or an amniotomy, is something that is often done to accelerate the labor and delivery process. It could also sometimes be done if there's an indication of a concern. So for example, we see changes in the heart rate tracing where we need to investigate what's going on. Sometimes it can be done so that we can facilitate placing internal monitors that will give us a closer eye on when those contractions are happening and how strong those contractions are, as well as give us a closer eye on the baby's heart rate tracing. And it literally looks like a little crochet hook, like a little hook. And you just snag the bag of water and break the bag of water. It typically is a longer cervical check. So typically if you tolerate a cervical exam well, it's just a few seconds added to your typical cervical exam. Internal monitors are optional. They don't always have to be placed just because your bag of water is broken. Sometimes amniotomies are done, as I mentioned, to accelerate the labor and delivery process. So if someone has been stuck at, say, 4 centimeters and it's been several hours, sometimes just breaking the bag of water is all that's necessary to keep things moving forward. She mentioned that the bag of water is clear. The alternative can be meconium in the bag of water. Meconium is where baby poops or has a bowel movement in the bag of water. This can be a stress response. Again, going back to labor being stressful, not just for the mama, but for the baby too. When meconium is present in the bag of water, we try to determine, is it a tiny amount of meconium? We call that thin meconium. Is it a moderate amount of meconium or a thick amount of meconium? Because sometimes those varying degrees of meconium can lead to distress for the baby and often will inform what happens at delivery, because in those circumstances, you want to prevent baby from inhaling and taking a big gulp of that fluid and that meconium potentially getting into baby's lungs and leading to damage and other respiratory difficulties later on because of that inhalation of that particulate material. There are several positions in which you can choose to push in. Either side is a good candidate. You can push on all fours. You can push using a squatting bar. You can push using handles or rails that help you kind of curl around baby and get in position for baby to easily navigate that pubic bone, get underneath that pubic bone for delivery. This is the bone baby's head. Lots of different positions. I've had mamas push standing up. So it really just depends on your pain control, your comfort level, listening to your body and doing what feels right for your body. Sometimes we'll change your pushing position if baby seems to respond better in one position versus the other. So for example, in some positions, you can get more compression of the cord, for example, and then help alleviate compression of that cord in other positions. So you'll see improvements in baby's heart rate tracing with different positions. So lots of different reasons why someone might push in one position versus another. When you're pushing, you want to push in your bottom like you're constipated. The position that this mama is in helps that baby again navigate underneath that pubic bone. So by holding her knees to her chest and her chin on her chest, curling around baby allows that baby to get in that ideal position for that head to come underneath that pubic bone. You want to push in your bottom like you're constipated. So you take a big deep breath like you're going underwater. And I mean, fill up all the way to your back. Try to push in your bottom like you're constipated and hold it in one continuous push for a count of 10. And then quick breath in between and push again. The longer your breaths are in between, there's an opportunity for that head to come back up. And you want to prevent that one step forward, two steps back type of thing that can happen when you wait too long in between pushing. Typically do 3 pushes for a count of 10 with each contraction. You only want to push with your contractions because you want to let your body help you. So that's a little bit easier to get to the finish line. The labor shakes, something that almost all of us experience, but hardly anybody talks about. Very, very common experience. Why do we even get them? It has to do with a whole lot of things. It has to do with adrenaline, hormones surging, temperature changes, your response to medication. Very, very common. They can happen whether you have a vaginal delivery or a C-section. Sometimes it's because you're cold. Sometimes it could be because you're in pain. All of those things could weigh in. I find that you just want to ride with it. Don't try to fight it. The more you try to fight it, I feel like the worse it gets. Typically doesn't last that long. Maybe up to an hour. And if it's super bothersome to you, there are medicines that can be given, typically IV. Demerol, for example, is one of them that can help you with the shaking, but very, very common experience. Think of chills, right? When you have the flu or cold or whatever the case may be, think of chills. That's what it feels like, and it's a very common experience. So a first degree laceration, first of all, it's very common for most first-time moms to tear. And it's just because nothing that big, that large has gone through the vaginal canal. There are some things that you can do in terms of techniques to relax the pelvic floor. There's also perineal massage that we talk about doing from about 37 weeks on, which encourages the tissue to stretch and not tear. Sometimes as you are in that second stage of labor and pushing, your provider can use lubricant to gently massage the perineum, which is the tissue at the bottom of the vagina, between the bottom of the vagina and the rectum. And by massaging that tissue, you're generally encouraging it to stretch and not tear. A lot of times slowing down and controlling how quickly the baby is delivering also encourages the tissue to stretch and not tear. But sometimes tearing is inevitable, and there are 4 degrees of tears. The first degree is just very superficial, right at the surface of the skin of the vagina or the perineum. Sometimes needs to be repaired if it's bleeding or if it's a big kind of separation of tissue to cosmetically bring that tissue back together. The next type of tear is a second degree laceration, which goes into the muscle, so below the surface of that superficial layer. A third degree tear involves the sphincters that go around the rectum. There are muscles in a circle that relax and then contract to control our rectum. And then the 4th degree laceration goes actually into the rectal mucosa. So, you're describing the worst type of tear, just as you mentioned. So it sounds like a part of this mama's birth plan was to keep her placenta, which is fine. That's her right to do. A lot of hospitals will make provisions for you to do so. Some moms will take their placenta home and encapsulate it and then later ingest it for reasons such as improving their milk production or decreasing postpartum depression. There is a lot of information in social media and in popular culture that suggests that these are benefits that mamas have experienced from this practice in the past. I do not have good medical research, strong, robust scientific studies that show that these benefits have been associated with ingesting or taking your placenta. So unfortunately, I don't have science-based evidence to back up the practice of doing that. I do have information that suggests that there is an increased risk for infectious diseases to be experienced by people who ingest their placenta, either because of bacteria that is infecting the placenta or how the placenta has been handled. So I don't have medical information that would suggest or would lead me to recommend to someone that they ingest or encapsulate their placenta for the purposes that I just went over. I've also had patients keep their placenta for religious reasons. I've had them bury them, plant trees in the place of where the placenta was buried. So all kinds of different reasons, cultural reasons, religious reasons why someone might want to keep their placenta. But if it's something that you want to consider, have a conversation with your OB provider and go over the risks and benefits with your OB provider to help you make an informed decision about that practice. Thank you so much for joining us this week. Do me a favor and share this episode with a mama who you know would benefit from the learning and the healing and the empowerment that happens each and every week on the Black Birth Stories podcast. We'll see you next week.
Want to go deeper? The conversation doesn't have to stop here. Join Melanin Maternity, our digital Black birth community, where you'll get expert guidance, real support, and a sisterhood that sees you. From live Q&As with birth experts to empowering discussions with other Black mamas, we've got you covered. Click the link in the description and step into the community you deserve.